Now we're going to be talking about pyloric stenosis. And pyloric stenosis results when the circular area of muscle that surrounds the pylorus, it hypertrophies, and it basically obstructs gastric emptying because it becomes very stenotic. There's a very, very small opening, as you can see in the picture on the right. You can see where the duodenum is here, stomach, and here's the pylorus. So, and then the pyloric stenosis is in here instead of being maybe 3 times the opening of that, 3 or 4, depending on how bad it hypertrophies. Then when the baby eats, you won't have that gastric emptying from the stomach. Usually, this happens more often in families that the mom or the dad may have had it. The baby's not born with it. It usually hypertrophies around the 4 to 8 weeks of age, and these are really, really fussy babies, and we'll get into the signs and symptoms in a minute. But usually, it occurs more often in male infants, and it's also associated higher in white infants than in African American or in Asian infants. So I thought that was kind of interesting. Heredity and family predisposition seem to increase that risk of pyloric stenosis as well. I can remember when my first son was born, being a pediatric nurse all those years, and I just knew that he had pyloric stenosis because the child, he really had GERD, and GERD really wasn't a disease of fashion back then. It was like he just ate too much, but he had one projectile vomiting, and I took him right away, and he was fine. He was gaining weight. He was, everything was fine with him. But when you have babies that have GERD, or mamas get real protective of their babies, and as we all know. So here's the signs and symptoms of a child with pyloric stenosis. As you can just see from the patho, they'll have progressive projectile vomiting, and it is forceful projectile vomiting to the point where you have to ask the parent, how far did it go? It just didn't seep out of the mouth. It projected out of the mouth. And this happens especially after eating. Sometimes you can, on palpation in the right upper quadrant, you have a firm olive-shaped mass that can be felt, and that's usually just before they eat. You can maybe feel that, and maybe just kind of putting the baby on your lap and having the head hang down just a little bit. Maybe you can feel it. Sometimes you can't feel it at all, and it's okay if you don't feel it, because a lot of times you don't. You also may see visible peristaltic waves from the left to the right upper quadrant immediately before the baby vomits. I saw, and I didn't include it on Blackboard, but I had seen one on YouTube, and that baby was just so malnourished, and that was the only way that you could see it, but it was just like a ball that went from the left side to the right side. These babies are dehydrated. They have absence of tears. You're going to note that. A weak cry, depressed fontanelle. Remember that anterior fontanelle has not closed, so we want to make sure that we assess that. A poor skin turgor, dry mucous membranes, and they can also develop metabolic alkalosis, and you're not going to be responsible for what the pH is going to be and all of that, but just know that these are very, very sick babies, and usually they come into the hospital, or if they haven't been diagnosed yet, with what they call failure to thrive, FTT, and we need to find out exactly what's going on with them when they come in with that, because that's just a preliminary diagnosis, and maybe because they haven't put on as much weight. It's usually 1 to 2 pounds per week, and they're just very irritable babies, very, very irritable. They're very hungry, very, very hungry. It's almost like a cardiac baby, that you'll see. But with this one, you're going to see that projectile vomiting, and that's very, very, that's a hallmark, sign of this disorder. So on our diagnostic assessment, we'll do that history of vomiting, those visible peristaltic waves, palpable pyloric mass, if you can see that. The doctor or the nurse practitioner will order an X-ray. Ultrasound is the gold standard. It's very non-invasive, and they may do a barium swallow, they may not. They may do an ABG, especially if this baby comes in and is severely dehydrated. We'll also look at our electrolytes. They usually have decreased serum potassium and sodium levels from vomiting and not being able to digest their formula correctly. Increased pH and sodium bicarb, and they'll have decreased chloride. Their indirect bilirubin may be elevated. Indirect just means that it hasn't gone to the liver yet to be processed and to be eliminated. So that may be or may not be elevated. It's not one of the key blood work that we look at. But we definitely look at our electrolytes with these babies. So if they come in, and usually, mamas are a lot more astute, I guess, than we used to be. But usually this can be done because surgery is the intervention for these babies. So they'll do a pylorotomy, and this is the incision of the pyloric muscle to release the obstruction. And it's usually done. It's done by laparoscopy. If the child comes in, though, and is severely dehydrated, they're going to manage the IV fluids and electrolyte replacement before they take this baby to surgery. They'll also put in an NG tube for stomach decompression, and that's really important to stop the vomiting, and that usually does stop it. So they'll have their NG tubes, maybe to gravity or to suction. And our pre- and post-op care is on page 437. You can read that. But basically, our post-op care is very, very important to follow the physician's orders, because when this baby comes back, he may or may not have an NG tube just to keep the stomach decompressed, maybe for about 12 to 24 hours, and then they'll start with and they usually have a very specific regimen of how they're going to be starting the fluids with these babies, and they'll start maybe with just some Pedialyte, and they'll be real specific of 15 mLs the first 30 minutes, see how the baby does. It's about monitoring that baby and making sure that the baby has no vomiting, that the baby has no fever, and the baby is gaining weight as the days go by and the baby's tolerating fluids. So that's real important for mamas to know that, and make sure that they know the feeding regimen when they go home. I think it used to be a little bit more regimented than it is maybe now, but at least every 6 hours, they should be fed and managed, and make sure that the parents follow up with their appointments. Very important. So in our nursing diagnosis, of course, we're going to have fluid and electrolyte deficit that's related to vomiting. It's usually that metabolic alkalosis. We're going to have it's a failure to thrive. I mean, these children are just they can be emaciated if it's left and nothing's been done about it. But I think parents now are a lot more astute about getting their children in, getting their babies in, and usually that 1 month visit is very, very important. And it's important as a nurse for you to elicit any problems with feeding, especially if you're a peds nurse and it's a new mama or even a third baby. So got to make sure that on the growth chart that they are increasing their weight to 1 to 2 pounds every week. Alteration in nutrition, less than body requirements related to that vomiting, and that's kind of self-explanatory there. I think it's, let me just look here. On evaluation, you want to just make sure that the child has a good skin turgor. The fontanelle is flat, it's not bulging or it's not depressed. They have moist mucous membranes. Their urine specific gravity is less than 1030. As you know, 1005 to 1030 is normal, and a sodium level within normal limits. That's important in their potassium. And make sure that the child's tolerating oral feedings without any vomiting, and make sure that the child's weight has returned to pre-illness level, and that usually should happen within a week. Make sure that the surgical site is clean, dry, and intact, and without any drainage or any redness. And can the parents explain the need for that surgery? And as you evaluate, can they explain the need for surgery and routine pre-op and post-op care, especially on going home? And is the child calm? Is the child content? Is the child free from any pain? And make sure that you address that with the physician. If there's something when the baby goes home, or you think the baby's still in pain, that he or she may need something, and just kind of assess the family unit, and see how they're doing, and see how the stress of having a baby in surgery, for the very first 2 months of life is very, very stressful for our families. So, okay, so that does it for pyloric stenosis.